fortunately, I have some cardiology colleagues in the room, so I can get their opinion on this. So this is a patient that she's 65. She came from West Virginia, and Gary, being from Ohio, knows what that means already. It means that they smoke. They have a family tree that doesn't branch, and usually have not taken very good care of themselves. So she was transferred to the Cleveland Clinic. She'd had a non-ST wave acute myocardial infarction. Came with already had a coronary cath with 3-vessel coronary disease. They'd also found a asymptomatic 80 to 99% right internal carotid stenosis and also severe PVD. And I was asked to see her because of both her PVD and her carotid management. She does have hypertension. She is morbidly obese. Her BMI is 45. She was a lifestyle limiting claudication. Her only surgical history was a cesarean section delivery. She was on aspirin, carvedil, and Lipitor. She smoked a half pack per day for 5 years, but hasn't smoked in 30 years. She weighed 113 kilograms, so with a BMI of 45, it gives you an idea she's pretty short. Otherwise, she had bilateral carotid bruise and had weak femoral pulses and no pulses distally. Otherwise, her exam was pretty much normal. So the right was a flush total occlusion, and here I would first say I'm not a cardiologist, and since Gary is, this is always the far right picture. My favorite is the Lima showing you what that looks like, giving a hint that maybe they need a cabbage picture, but she has a moderate LAD disease, and she's got a mid-circ lesion. So, Gary, your thoughts on her coronaries?
Yeah, so these are the ones that are actually, high risk because they have triple vessel disease. I don't know if her LV function was normal or not with her non-ST elevation in mind. But these are the ones that give you, this is left main equivalent. So this is, if you're going to have to take somebody to the OR, this is going to be somebody who is going to potentially give you problems because they've had a recent cardiac event, which raises it to another level. So, and she's got symptoms. So, those are the bad actors here.
So she's got a preserved.
Let me ask Dr. Jaff a question. What do you think, Mr. Calcification categorization? What do you think of that?
I don't know how to do it in the coronaries.
Well, I'm not talking about the coronary.
So before I answer that, Sean, on this right panel here, am I making up that there might be a left subclavian lesion?
There is a significant left subclavian lesion.
So that's important as well.
So
lame off that, right?
Seeing that I would have some help by
Did you see that aortic calcification?
it is very calcified. So I figured Michael would be here, and how could I remiss if I was going to show a cath that needs some help, because I would lie if I said I was good at reading that. We have some ultrasound images of both the right carotid and the left subclavian, and so you can see the right internal carotid origin up on the top left image has a velocity of 4/4/136. The common velocities are actually pretty unremarkable, and you can see it is calcified, but there's not a ton of acoustic shadowing on the lower left image. But as you can see, her left subclavian velocities are 292, which are elevated, which is going to give you a 50 to 99% stenosis in our lab. So she also had a CTA at her outlying hospital. And
Sean, was the vert retrograde?
The vert was retrograde on that side.
This is a great case.
So as you can see here on those images, we'll blow this up a little bit. Here's what her right internal carotid looks like. We can see that a little better on the 3D volume rendered image. Because of how tight it was, it sort of has dropout. And now let's get to her PAD. So
Sean, before you get to her PAD, did they go up to the brain?
They did not.
Okay, so you don't know if her collaterals are intact.
Right, so this is all outside workup she'd had.
Okay.
So we did do PPRs at the clinic, and you can see her resting ABIs are 0.3 on the right, 0.3 on the left, and really has, if you look at her segmental pressures, clearly based on physical exam as well, she had diminished femoral pulses. She has inflow disease.
So does she have ulcers too?
Didn't have ulcers, but
good.
she does have dependent rubor. So So I don't know about everybody else's institution, but as always, we were really stuck waiting for the cardiac surgical opinion, and not surprisingly, here's what they said. Oh, we'll take a pass. She's pretty complicated. If she has EF issues coming off the table with her inflow disease, balloon pump options aren't as good, and they said, how about you and the cardiology folks work out those issues for yourselves? So I called Irving Franco, who's one of our senior cardiologists, and I said, well, unless you fix the heart, I'm not going near anything else. So he took her to the lab, and he really felt that the CTO on the right wasn't really contributing to that much, and she had really good left to right collaterals, and went ahead and put in a drug-eluting stent in the stirred lesion here. You can see both a pre and a post images, and felt the LAD was moderate and called it a day.
Okay.
So now I'm left with a lady who has had it non-STEMI, and she's had one of her coronaries fixed. The right still occluded. The left he didn't feel was as severe, so maybe now it's remaining one vessel coronary disease.
Do we know the EF though?
Her EF is 60%.
So it's good.
It's preserved, and her echo actually has pretty good function, so no real issues. So now we're stuck with is she really a candidate in the United States for carotid stenting? So she did have an MI, but she has been revascularized, and so this is kind of one of those gray areas. If I could do what I want, I'll give that in a minute, but really for us, it's about whether or not you can show they're high risk to get paid, and I think this is a gray line. I mean, she's been partially revascularized, she's not been totally revascularized. I think you could make an argument either way. Unfortunately, my cardiologist felt she was no longer high risk.
Yeah,
not what I was hoping
recent
to do.
MI you can still keep as
right.
high risk.
So just to add a little fun in there,
Just no neck.
That's hilarious.
they felt she was not super high risk. I was not as convinced, but I figured if I was going to have to then do a carotid, I would attempt it under cervical blockage, just to give you guys an idea of what she looks like. This 3D volume rendered imaging, she's really 45 BMI. So the case starts out okay. We start under a block, and when I
Hilarious.
So before this goes, let's step back though. So when you were trying to decide whether to do stent or CEA, what really went through your mind?
Why won't you say she's high risk in the chart, Irving? Please say she's high risk in the
I mean, but you could have said
I know.
just because she had a recent cardiac event,
Yeah.
she had abnormal enzymes. You could say, and she has a neck like this, so she's high cervical because her cervical's up around her forehead. I mean, but the problem is she is actually non-symptomatic in the United States.
Right.
So unless you get the private payer to pay for it,
So she's
not going to be
West
reimbursed.
Virginia Medicaid, which means
So
they're not going to pay for
they're
it
not
no
gonna
matter
pay
what. So I have a non-symptomatic, potentially high-risk patient who, if I do surgery, it'll be paid for. If I do stenting, the Cleveland Clinic will pay for it.
Right, exactly right.
And so,
donation to the charitable.
Unfortunately, I think carotid stenting would have been my preferred approach, but sometimes finances drive a lot of the decisions, and this had a lot to do with that. Could she have been a
No, she's high risk.
Because she's high risk.
She could,
But she's not. Your cardiologist just said she's not high risk.
but the definitions that the trial had.
Oh, the recent MI would make her.
The MI would, by the trial, would.
Yeah.
Our poor European audience is scratching their head about
Thinking, what is wrong with the United States? Why we have to do
Okay.
So we go to do an endarterectomy, and we're doing it under cervical block. And as I'm removing the intima from and the media from the internal carotid, the back wall gets a little thin. And when I patch it, the patch gets a dimple in the middle of it. So I took that off. I repatched it with a little bigger patch. And I routinely do a completion carotid duplex. And you can see here on the top right image, I didn't take a photograph because usually when you're having not a great day, photograph. The patch is dimpled in. And the carotid velocities, along with that, do not look very spiffy, Michael. I mean, those are still pretty concerning. And so, so I don't know, Martin, if you've done an endodorectomy where interop, I'm actually on a table that has a big bar right where the head is, so it's not a place where I can really easily bring in fluoro. I can close her neck up and go to one of the fluoro rooms when my partner finishes, which might be another hour or two. And so I'm sitting with my awake patient with a intraoperative duplex and a dimple in my patch that doesn't look spiffy. So, your surgical colleagues calling at this point, Gary, what are you going to tell them?
Well, Tom, I think it's supposed to be a revision surgically.
So, I think one thing you can do is do a bypass, doing a bypass in this short, fat neck awake. She was, we'd been going on about an hour and 20 minutes, and one of the things about doing an awake carotid is they don't tolerate a whole long period of time. And so I actually did something I'd never done before. I've done ultrasound-guided interventions, but never a carotid stent. And so let's see if I can get. So what I did is I actually stuck the common carotid below my patch, and under fluoroscopic guidance using the foot probe, was able to negotiate a wire through the lead. And then ultrasound guidance took a carotid stent, was actually really easy able to visualize where the stent was, could see where my endpoint was, both see the proximal and distal end of the stent.
And you're still not closed, right?
Oh no, this is right. The neck open. So you can see now the removal of the delivery system of the carotid stent.
What kind of stent did you do?
So I used a Protégé RX, a tapered 6 to 8 millimeter Protégé RX stent. And then I took a balloon to post-dilate it. As you can see, I didn't quite get all the air out of the balloon, so I see a little bit of air remaining. I didn't get the best prep. And then backed out the balloon. And, the downside is that all the delivery systems are kind of long, so I'm standing at the foot.
Oh, yeah.
While my fellow's holding my sheath and the ultrasound probe over the neck. And you can see, here's with the stent, just some still images. You can see the stent before we deployed it, and then after we post-dilated, and then completed another duplex and once again achieved normal velocities. And for protection, I just clamped the common carotid proximal to my axis and had a vessel loop around the external and superior thyroid and pulled up on that. So essentially just created a surgical flow reversal and then aspirated through my sheath. But I wasn't really worried about debris since I'd already endodorectomized the vessel, and I knew by duplex that there was no remaining debris. And she actually did well. I saw her back 2 or 3 weeks ago, and her duplex actually remains normal. Interesting enough, velocities always are a little higher when someone has been stented than when they're not. Their criteria is a little bit different, but still looks pristine. But I thought it was an interesting case where sometimes surgery is a great option, but we always sell it as perfect, but it's not.
And before everybody runs out and does this for their surgeons, I'll relate a case that we had similar to this early in my career.